Welcome to the University of Washington Tracheotomy Care Training Module on finger capping, button capping, and talking around a tracheotomy appliance. By the end of this video, you will be able to explain the rationale, indications, contraindications, techniques, and risks of finger capping, button capping, and using a speaking valve, and performing decannulation of a tracheotomy. When a tracheotomy appliance is capped, the patient can attempt to breathe through their nose and mouth. They are no longer breathing through the trach tube. On exhalation, capping a tracheotomy appliance can enable air from the lungs to come up through the trachea, around the trach tube, and up through the voice box to create sound. In order for capping to be successful, there needs to be enough space around the trach tube for air to pass easily. This means the tracheotomy appliance needs to be small enough, and the patient's airway has to be big enough to allow air to pass between the appliance and the airway. If there is inadequate escape or egress of air above the trachea, carbon dioxide can build up in the lungs and lead to acid buildup in the blood, shortness of breath, fast pulse, headache, confusion, and lethargy. One of the simplest ways to test if a patient can tolerate capping of the trach is to perform finger capping. To finger cap, a patient takes a deep breath in through the open trach tube and then places his or her finger over the trach tube to seal it as they exhale. This allows the exhaled air to pass around the trach tube and up through the voice box. If there is enough airflow, they may be able to speak. If the patient is able to exhale comfortably with the trach tube covered, they may then try inhaling with their finger blocking the trach tube. If this can be done comfortably without difficulty breathing or shortness of breath, this suggests there is enough space around the trach tube. If finger capping is successful, a medical provider may clear a patient for use of a speaking valve. The speaking valve is a one-way valve that allows air to go in through the trach tube but seals it up from behind, forcing air to go up and out through the vocal folds, possibly allowing the patient to speak. A major advantage of the speaking valve is that it is hands-free. Most speaking valves attach to the front of the tracheotomy tube, though some are placed in the ventilator circuit when a patient requires long-term ventilation. In these cases, ventilator settings must be adjusted to account for some leak around a deflated cuff or cuffless tube. A speaking valve can also help a patient to control the pressure between the outside world and their throat or airway, and thus assist with coughing and swallowing. An important criterion for allowing speaking valve use is that the patient must be awake and alert and able to remove the valve easily if they are having trouble breathing. Initially, it should be used only with supervision, and if a patient is unable to remove the speaking valve on their own, it should only be used with supervision or under very specific circumstances after discussion with the treating physician. If a cuffed tracheotomy tube is used with a speaking valve, it is very important to verify that the cuff is deflated. Use of a speaking valve with an inflated cuff can prevent the air from escaping from the lungs, which can lead to hyperinflation, carbon dioxide retention, and ultimately a very dangerous situation. Button capping should never be performed with a cuffed tracheotomy tube, whether the tube is inflated or not, because of the turbulence of airflow around the trach tube and the risk of inadequate egress of air. Decannulation is removing the trach tube completely. This is typically performed when the patient no longer needs the trach tube. For example, if the patient needed ventilator support during an acute illness, decannulation may occur when the patient can breathe on their own without the ventilator. Prior to decannulation, capping trials are often done to ensure that it will be safe to decannulate. Generally, a patient will start by capping for a few hours a day and gradually increase the amount of time the trach is capped. The length of the capping trial is determined by the medical team and is usually at least overnight, but can extend several days to weeks depending on underlying medical conditions. If a patient is particularly concerned, a capping trial may be performed in the hospital, sometimes with pulse oximetry. When a capping trial is done as an inpatient, it is especially important to make sure that the patient has access to the call button and other potential needs. Of note, while a trach is capped, there is still an appliance in the airway. This means that it may be even easier for the patient to breathe once the trach tube is removed. If decannulation is recommended, the trach tube will be removed and a dressing is placed over the trach site. The following supplies are recommended for decannulation: eye protection and mask since the procedure can elicit a cough reflex from the patient, moist gauze or sponge to clean the stoma site, dry gauze to dry the stoma site, and trach site dressing. First, counsel your patient about what to expect from the procedure. Then, if there is a cuff, ensure it is maximally deflated. With the trach tube being held in place, release at least one tracheotomy tie. Then remove the entire tracheotomy appliance and ties. Cleanse the trach site with a moist gauze and dry the trach site, and then apply the occlusive dressing. After the trach tube is removed, the site will usually heal on its own after a few days to weeks without additional treatment. There will be some air and mucus that leaks through the stoma site, and a bandage is placed over the site. This should be changed as needed, but typically at least once a day. Keeping pressure over the bandage with 1 or 2 fingers will help keep air from leaking while speaking and coughing, and may help the wound heal faster. Approximately 1 week after the wound has fully healed, we advocate for gentle circular massage over the wound site to reduce tethering of the stoma site to the larynx. If the wound fails to heal, this may be a sign of a persistent upper airway obstruction, since air prefers to follow the path of least resistance and may continue to flow through the tract, keeping it open. Sometimes the wound does not close even after several months. When this happens, there is a persistent communication between the trachea and the skin. This is called a tracheocutaneous fistula. A procedure may be required to allow the tract to close. In this module, we describe tracheotomy capping, speaking valve use, and decannulation, including appropriate procedures, their rationales, and cautions.